and thank you for inviting me to talk on strategies for increasing day case laparoscopic cholecystectomy rates. So there are 63,284 laparoscopic cholecystectomies performed last year, or in fact cholecystectomies rather than laparoscopic cholecystectomies, of which 51% were performed as day cases. As you'd expect, there's some variation, ranging from the highest areas, nearly 60%, to around 44%. And within hospitals, you can see a huge variation there of day case rates. So, for the purposes of this little discussion, I think we're just to clarify the wording of day case. I'm meaning patients who are home on the same day, i.e., an overnight stay, which is the usual UK definition, rather than the sort of 23-hour stay, which is a bit of a fudge. Why is it important? Well, it's important certainly for cost efficiency and savings. Cost of an overnight hospital bed in most hospitals is about £500 or so. So if we can do it as a day case, that's a significant saving. It's probably also an indicator of good practice and is likely to become a performance-related outcome measure and possibly even a local sequence, so it may actually relate into funding or penalising people if it's not sorted. So there are a number of steps that we can possibly improve the number of day case rates. First, of course, is patient selection. So there is a little bit, I haven't evidenced things with references, but I will point out where there is some evidence or no evidence really. So there is a little bit of evidence that men have a higher rate of admission following cholecystectomy on day case lists. So you can select a little if you want to do that. Age, of course, is relevant at the extreme ends of it, but that's more often about social factors, where they've got someone to go home with. Comorbidities, we can push the boundaries there if we work hard by getting better preoperative assessment. And with many of the statements that I'm going to make, actually it will come down to, as you'll see in the end, as a cost thing. If you want to get more day cases through and you want to throw more resource at it, then you can actually do that. But it will in itself incur some costs. So if you work hard, you can get your patients with your warfarin off, you can get your patients converted to enoxaparin, and you can get them done as day cases that way. If you're lazier about it and take the easy option, then bringing them in as an inpatient may be an option, maybe a different, maybe the standard way of doing it. The gallbladder pathology, if you exclude certain procedures, then you will reduce your admission and readmission rates. But if you want to increase your day case rates and you're prepared to accept higher admission or readmission rates, then you can ignore the gallbladder pathology. But you will get higher admissions and readmissions if they've had pancreatitis, acute cholestasis, and there's certainly patients who've had ERCPs are invariably a more difficult operation and therefore more likely to fail at a day case. And obviously the home situation, if you go to the efforts of making sure that if they can get someone else in, they get a neighbour in, if you work hard and push hard with the patients and they're committed, then you can get more patients through the door that way. So how do we measure success of whether we're reducing day case rates? Obviously the proportion of the total there, and that's the overall indicator if we can see our proportion of day case rates going up. But we need to look at admission and readmission rates as the other side of that. So if you've got are you happy having 100% of your patients as day cases if you accept a 10 to 20% admission and readmission rate, for instance? And by admission, I mean patients who don't go home on the day of the day case rates, and readmission being patients who have gone home and then have to come back. And you need to take both of those factors into consideration. As well as complication and conversion rates, which will be smaller in the day case routes. So in terms of, again, steps where we may improve the number of day cases, I think one of the key factors is actually the preoperative assessment and counselling of the patients. From the very word go, patients need to know that they're having it done as a gay case if you want them to do that. If there's any doubt in the mind on any of these pathways, they've all had their auntie who had their cholecystectomy done as an open operation. They were in hospital for 5 days, so they've already come not expecting to go home as a day case in some cases. So you need to emphasise this to them. This is the normal way we do it. Most patients in the unit go home as a day case. It needs to be pushed from the word go if you want to get good day case rates. And everyone needs to sing from the same songbook, because they're going to be seen again by a pre-operative assessment nurse, and they're going to be seen by an anaesthetist, and they're going to be looked after by different nurses and discharged by different nurses. So everybody has to be emphasising the importance that this is going to be a day case and the safety elements of it, and that it is okay, this is normal. Anaesthetic agents. There is no doubt that if you have anaesthetists who are prepared to and are experienced in total intravenous anaesthesia, there is evidence that these patients, that the recovery times and the washout of the drugs is much greater than in inhalational agents. But it's costly, it's more time consuming given IV anaesthesia, and I think in practice there are very few that are done this way. But selection of the drugs that are used and familiarity with it. If you have dedicated teams of day case surgeons and anaesthetists and the rest of the operating staff, then you will get better day case rates. If you introduce expensive drugs like Sugamadex, you can certainly improve the number of patients that will go home. In randomised trials with Sugamadex, which is a reversal agent of neuromuscular blockade, the difference in the wake-up time from giving them nothing, is 90 minutes, to giving them neostigmine, which is the cheap version, 50 minutes, but they wake up in 1 or 2. The neuromuscular blockade is completely reversed in 1 or 2 minutes, but it costs £20. It's £20 per case, and it's getting more marginal now. You can actually work out a saving, because recovery time is estimated at £1.5 per minute, and the operation time in this study was estimated at £4 per minute. So you can argue that you get the payback, but of course that's a different budget, isn't it? But there's no doubt that if you change your anaesthetic agents, you can do it. Again, obesity. You can push more patients through with day case, and they were originally very selective with it for 2 reasons, really. Firstly, the surgical component of it, but many more people are familiar and happy with operating on obese patients laparoscopically. But also on the anaesthetic side, most anaesthetic agents are lipid soluble and will hang around in the body more, so they're less likely to get it washed out of the system, and they're more likely to have the side effects of the drugs, and then therefore more likely to fail day case. But if you're pushing, that's another area where you can push them through more. The timing of the operation is one of the few evidence-based studies that have shown, which makes common sense really, if you've got an all-day list and you try doing your lap choles at 5 o'clock, you're less likely to get them home before midnight than if you do them at 9 o'clock in the morning. So a bit of ordering of the list. Do your lap choles if you've got a afternoon list. You can get the 2 lap choles done on the start of it and 3 lap hernias later, and you'll get a better success rate and less readmissions than admissions. And if you try and get your sicker, less likely to get home patients done at the beginning of the list, again, you will increase your day case rates. And here's the 1 or 2 evidence-based ones that have shown that age 50, the fitter the patient, no history of previous cholecystitis, and if they've got non-dilated bile ducts, those patients have more successful day case rates than others. And that's the evidence for that. The surgery. Is a quick surgery important? Yes, it is, but it's really about 2 things. It's about the length of anaesthesia again. So as Hassan Malik showed very nicely, you can do a lap chole in 8 minutes, and that patient is certainly more likely to get released as a day case than if you're struggling through on an hour, which may of course be multifactorial. It's not just the surgeon's speed, it's the difficulty of the operation. But there are technical errors in it, and patients, we've all had that patient where you've spilt the gallstones and it adds another 30 minutes as you try and hook out every last little gallstone. So if we can get technically better, we can get faster. Whether we do OTCs, it adds around 15 minutes, it's estimated in most studies, to a procedure. So if you're selecting and you're happy with not doing routine cholangiograms, then that may add another factor to it. There's surprisingly little evidence that actually local anaesthetic or any of the other things that have been tried, and there's no evidence that peritoneal swilling around of lignocaine or blockades or anything other than adding time and frustration to the surgeon, there's very little evidence that it makes any difference in getting your patients home any quicker. So in the recovery phase, I think it's important to get the patients normalised as soon as possible. Again, it's that idea of working them up beforehand. You're going to wake up, you're going to have a cup of tea, you're going to get mobile, you're going to go to the loo, you're going to go home. If they realise it's a normal pathway. And to do that, you've got to get the balance. The anaesthetist, again, when we're talking about success and failure, I think it's far more important to have a really experienced day case anaesthetist than an experienced day case surgeon, because most of the reasons for admission are on an anaesthetic side, and it's by reducing getting the balance of opiates right, so they wake up without pain, but you haven't zonked them out completely, so that they're going to be stuck sleeping for the next 4 or 5 hours, and they're not get all the side effects from those opiates. We get them off their IV fluids quick. They need to be drinking and normalising early, getting that bowel function recovering. So we looked at readmission and admission rates in our group. I've grouped them together for the simplicity of this. But we might call surgical causes, i.e. they were converted to open, or there was some bleeding in the operation, we want to keep them overnight because we're uncertain, or we're worried about a bile leak, so we've left a drain in. Actually, only 10% of our admissions and readmissions were for that cause. 10% were for social things. Oh, I forgot to get my daughter to come and stay with me, so I've got no one at home, and we couldn't get anything sorted out, or retention of urine. But again, what we might class really as primarily anaesthetic-related things, it's pain control, and even more so, nausea and vomiting. And if anaesthetists are more familiar with day case things, they bombard them with the full range of all 4 anti-vomiting drugs, then you're more likely to get them home. So can we increase day case rates? Yes, we can. You can increase them with many of the things I've highlighted there, but it's a question of how far do we want to go with it, how much are we prepared to invest in it, both in terms of cost, in terms of anaesthetic agents, reorganising our lists, paying extra staff to be on later at night so that they can get more of them home, and what admission and readmission rates what do we want to accept. The higher you push up your attempted day case rate, the higher you're likely to have of your admission and readmission rates as you're getting on those more marginal patients. Thank you.